Good morning, sir.
This lecture is dedicated to the role of osteoscintigraphy in diagnostics of the malignant bone tumors. And as introduction, I want to show you this slide on which you can see how the detection, the imaging methods of the tumors of the bones evolutionized, developed in a time. So on this slide, we can see bone scan, the example of the bone scintigraphy, radionuclide method of examination. We can see increased accumulation of radiopharmaceutical in this dark region in the suspicion zone. We can see the same patient shoulder on X-ray. We can see the deformation, the abnormal shape, size, and contour, and radiation density of the shoulder on X-ray. This is the presentation of bone metastasis of the left shoulder. This is the method that was invented more than 50 years ago and still used in contemporary diagnostics of the oncological diseases, bone diseases. But now we got new methods of diagnostics which allow us to detect bone tumors more with higher sensitivity, higher specificity. And on the upper part of the slide, we can see a new, relatively newer method. It's a single photon emitted computed tomography, or SPECT. If bone scan and X-ray, we may name them as the planar methods of diagnostics. It means that we perform this method in one projection and all organs overlap over each other. Then we can perform image in the second projection, and again all organs may overlap over each other. In case of SPECT, we may achieve also planar imaging, but we may achieve a cross-sectional imaging in three projections in the axial, sagittal, and coronal, in order to receive more precise imaging information slice by slice. And on this image, we can see also more sophisticated contemporary method of the imaging of the bone tumors, positron emitting computed tomography. Here we can see this result of this imaging. PAT, it's also radionuclide methods of diagnostic, as well as SPECT, as well as bone scan, three methods of the contemporary nuclear imaging: bone scan, SPECT, and PAT. Here we can see result, also not very sharp details, but sharper than bone scan. And on this part of the slide, we can see computed tomography. So this is a hybrid imaging type. We overlay information achieved during the PAT and information that's simultaneously achieved during the computed tomography of the same patient during the same scanning time. And we can see overlap fusion imaging, which allows us to achieve anatomical details of computed tomography and metabolic, functional, morphofunctional information of the positron emitting tomography in order to maximally precisely detect tumors of the bones and other systems. Also, MRI is very useful method of diagnostic. Here we can see on this part of the slide, even sometimes more sensitive to bone metastasis than even bone scan. And bone scan today, it's a golden standard in diagnostics of the bone tumors. And also another hybrid variant of combination of single photon emitted tomography and computed tomography. Colorful parts of the image, it's a SPECT, nuclear imaging, and black and white, it's a computed tomography overlay over each other, and also another example of the PET-CT scan. Also, sometimes we use angiography, it's an X-ray method of examination, as well as computed tomography, it's X-ray way of examination. During PAT, SPECT, or bone scan, we use gamma waves. So here on this slide, you can see a wide spectrum of imaging techniques for the detection of the primary and secondary bone tumors. So which techniques should be selected for the imaging of detection of primary bone cancer, secondary bone cancer, it means metastasis of the tumor into bone. So it's a very interesting and important question. According to the statistics of an American United States National Cancer Institute, primary bone cancer and joint cancer is relatively rare pathology, and we observe bone and joint cancer in approximately 0.2 of all due cancers in United States. So this is relatively rare disease. Vice versa, bone metastasis, it's not rare disease. And on the first place, we can see breast cancer, lung cancer, prostate cancer, colon, rectum cancer, bladder cancer, melanoma, lymphoma, thyroid cancer, kidney cancer, leukemia, and bones and joint cancer. It's on a 29th place in this chart. However, if we will look at the statistics, this is a relatively little disease. Only 67.4% of the patient who got primary bone cancer will live 5 years, will cross this limit threshold 5 years, and the rest will die during the first 5 years. And if we look at the statistics, again, according to the National Institute of Health of the United States, we can see that death rates due to the bone cancer, primary bone cancer, what means primary, the tumor start growing initially from the bone, yes, not in another organ. Secondary, it means the tumor grows in the prostate, in the kidney, and only casts metastasis to bones. This is secondary bone cancer. So we talk about primary bone cancer. So the death rate still on the almost the same level. It means that improvement in methods of diagnostics and treatment does not improve significantly the impact on the survival of those patients, unfortunately. And the new cases, the morbidity stays the same during the last 20 years. It's also not very good epidemiological situation. In Ukraine, maybe it will be of interest to you, you can compare with your countries. According to our cancer registry, the mortality and morbidity rates a little bit decreased during the last 5 years, but still remains on the high level. If we talk about the primary bone cancer, for example, 2015 year, it was 61 persons detected with a primary bone cancer in Lviv region. Lviv region, among more than almost 8,000 of newly detected different cancers. So it's relatively small population, but still we understand that it's lethal pathology and should be detected as early as it possible. On this chart, on this slide, we can see how the normal bone is looking like, the proximal head of the bone, and we can see the bone marrow here, the cartilage, epiphyseal line, compact bone, and the bone cancer, and cancer growth covers shaft of the femur. This is head of femoral bone. If we look at the classification of the World Health Organization of malignant tumors, we can divide different bone tumors, not only malignant but different bone tumors, into such a classification. First, as you can see from this slide, it's a chondrogenic tumors. Among them, we can name the atypical cartilaginous tumor, chondrosarcoma of grade 1 or grade 2 and 3. Dedifferentiated chondrosarcoma, it's a malignant tumor. Mesenchymal chondrosarcoma, malignant tumor. Clear cell chondrosarcoma. We talk here only about the malignant tumors. Osteogenic tumors like low-grade central osteosarcoma, conventional high-grade osteosarcoma, tendiogenic osteosarcoma, small cell osteosarcoma, secondary osteosarcoma, and so on. Notochondral tumors like chordoma, vascular tumors like angiosarcoma, other malignant mesenchymal tumors like a fibrosarcoma, leiomyosarcoma, and other more rare tumors like Ewing sarcoma, adenoamelanoma, and so on. So here you can see that we got a lot of different histological subtypes of the bone tumors, depending from which part of the musculoskeletal system, they grow, and the diagnostics and treatment of those tumors and prognosis and general approach to these tumors very often is different. So we can show here on this slide the general approach to the diagnostic workup in case of diagnostic primary bone cancer, according to the very famous guidelines. We got such an organization like a National Comprehensive Cancer Network. It's a American or North American association of the many leading oncological institutions. And according to these guidelines, they got guidelines on different oncological pathology. We can select such a main points of the diagnostic workup. First of all, is that the biopsy should be performed prior to any surgical procedure. All patients with a suspected bone sarcoma should undergo complete staging prior to the biopsy. What means staging? According to the TNM classification, it's the size of the tumor, spread of the tumor, local and distant. Standard staging workup for suspected primary bone cancer should include chest radiograph or chest CT in order to detect pulmonary metastasis, appropriate imaging of the primary site, means of this site where this primary tumor is growing. It could be plain X-ray, less informative, MRI for local staging, very informative method, and or computed tomography scan. And also we may perform bone scintigraphy, which is actually the main point of interest of our lecture. It's nuclear imaging method. Also we perform complete blood count and perform measuring of such oncomarkers, non-specific actually, but still very useful, as the LDG, lactate dehydrogenase, in case of more than 280 international units per liter, we can suspect the presence of the malignant bone tumors. In case of the alkaline phosphatase level more than 147 international units per liter, we also may suspect the presence of the malignant tumor. If we talk about the application of the clinical nuclear methods of diagnostics in detection of the not only bone tumors, but actually differentiation between bone tumors with the other benign conditions, you can see on this slide the book which you use for the preparation of practical seminars. I hope you have it. I sent it to you. Clinical nuclear medicine. We can see such table in which we see the application, the points of application of nuclear imaging methods like osteoscintigraphy for the different bone diseases. Sure, we can find here the primary bone tumors. Also, we can see the investigation of malignancy in case of the initial staging of malignancy, in case of the discordant scan X-ray findings. We may use additional methods of nuclear imaging, assessment of extent of the disease, monitoring of progress of disease, assessment of the response to therapy, and hypertrophic pulmonary osteopathy diagnostics. This is the main point for using of bone scan for detection and differentiation of the malignant bone tumors. It's need to be emphasized that nuclear bone scan is never used in a primary setting for the primary diagnostics of the bone tumors, but usually as additional method of diagnostics. After we already perform MRI or USG or CT, we add this method to just add the information important for the differential diagnostics. But also we can see here another application of the bone scan for the investigation of the bone pain, which can occur in case of metastasis, but also due to inflammation. It may occur due to primary bone tumor or due to metastatic bone tumor. Differentiation between the benign bone tumors, trauma, avascular necrosis, infection, osteomalacia, Paget disease, which is osteodystrophic disease, and so on, sport trauma, and so on. So as you can see, a very wide spectrum of the disease could be diagnosed by the means of this method. The technique. We perform intravenous injection of the 740 megabecquerels of technetium 99M MDP. This is methylene diphosphonate. The isotope technetium 99M is combined with the formula MDP to achieve this radiopharmaceutical, which will be selectively accumulated within the bone lesions. The scanning we perform 2-3 hours after the injections. We must wait until this radiopharmaceutical will be accumulated and spread it within the bones. The duration of the scan is from 30 to 70 minutes. We usually perform two-dimensional projections of scintigraphy, which is usually enough. You saw this result of this imaging on this slide. This is anterior, this is posterior scan. And sometimes if lesion is small, we may perform additional scan, which is called SPECT, single photon emitted tomography. If the lesion is less than 1 centimeter, in a small bones like ribs, like vertebrae, we may perform additional scanning during the same period of examination. And the typical radiation dosage obtaining by the patient during the bone scan is relatively small, is approximately 6.3 millisieverts, which can be compared with the one computed tomography scan without contrast. So single phase computed tomography, if we perform, in case of oncological pathology, we usually perform multi-phase CT. The dose during one CT is approximately 20 millisieverts, so many times more than one bone scan. We will have a small break and then we will continue.